Hello and welcome to this Hoosier Extracorporeal Science Conference brought to you by Heartbeat Perfusion Solutions, which is a national provider of specialized perfusion and extracorporeal membrane oxygenation services. I will be your host today for our webinar and our presentation with Dr. Liang, who is the CEO of Lifemotion Medical Technology. He is a board certified and licensed clinical perfusionist who has worked both in the United States as well as China. His expertise includes extracorporeal life support, mechanical circulatory support, aortic surgery, and research on ventricle assist devices, blood management, and organ protection. In his presentation today, we will explore ECMO on the go and the concepts of ultra-compact ECMO systems. Thank you so much for being here, Dr. Liang.
Thanks a lot. Thank you. Thank you for inviting me.
I will let you go ahead and share your screen and begin your presentation.
Okay. Thanks a lot. Thank you for the invitation. First, I would like to appreciate Heartbeat Perfusion Solution giving me the opportunity to present my topic today. Today's my topic is ECMO on the go, the concept of ultra compact ECMO system, revolutionize care and patient transport. So this is my disclosure. I'm currently working as a Chief Medical Officer at Lifemotion Medical Technology Incorporation. So this is the agenda of my today's presentation. Those of the area I want to cover today. I want to give a brief overview of ECMO. So that's pretty much everybody know it. I mean, if you have an audience for this presentation, you pretty much already know. So that's just give a brief overview. And then the topic, the discussion on the need for portability of ECMO system. And we'll talk about evolution of ECMO system and also the component of ultra compact ECMO system. And then we'll talk about the logical of ECMO on the go and the challenge and complication you're facing when you deal with a small compact ECMO system. And also the future of the portable ECMO. And then later on, I will give you some case study and clinical applications. The last session is if you guys have any question, I can give, and we can discuss it. Extracorporeal membrane oxygenation, ECMO. So this is actually starting from cardiopulmonary bypass. Is a heart and lung support system during this year. Is starting from the 60 from cardiopulmonary bypass and the later progress into to upgrade to the today's. We can see old system is much smaller, much compact, and compared to old system. So ECMO actually is a form of life support. Its function as artificial heart and lung for patients with a severe cardiac or respiratory failure. So the purpose of ECMO is act as a bridge to either to recovery or to other definitive treatment, which is or a transplant, which is by more time for the patient. So to allow the patients sick to give the doctors, give the clinician a time to do any diagnosis work to find any problem, the primary cause of the disease, and have a better treatment. 1971, Dr. Dana Hill used a cardiopulmonary bypass for the first time to provide support. Successfully treat a young man with ARDS and later successful wind. This created the first world first successful extracorporeal life support. When we talk about ECMO, one person we really can miss is Dr. Bartlett. Unfortunately, he just passed recently, and this is a loss of the whole ECMO world. And he's a true hero and pioneer in the field of ECMO. He pushed ECMO technology, extracorporeal life support technology, from operating room to the bedside. Also, from the laboratory to clinic, and he expanded usage not only adult and to the children and even the newborn. So one will consider ECMO treatment or support. So when a patient has a severe life-threatening heart or lung failure, unresponsible to a conventional therapy, then we'll consider support the lung system or support the circulation. If the patient develop acute respiratory distress syndrome or severe infection on the lung of pneumonia, or the patient has some genetic disease or congenital disease, need a lung transplant, so or have a severe asthmatic exacerbation. So we need support. We need to help the patient to get better oxygenation and remove CO2. So that's where ECMO act. And then for the other part, if the patient suffer from a cardiogenic shock, and then or have a cardiac surgery, has a post-cardiotomy shock, or the patient has a heart failure, need a transplant, or a durable LVAD system, then we need a ECMO to support the whole heart, the heart and the lung. There are two modes of ECMO. Everybody know it. One is the VV ECMO. So you drain, like this diagram showed, you drain the blood from a big vein from the patient, and through the pump and oxygenator, you get get oxygen from the oxygenator and get rid of CO2, and you're pumping the blood back to another vein, big vein, back to the patient. So this is a VV ECMO. So that's, like I said, that's when the patient has a lung problem, it can get a better oxygenation or can get rid of carbon dioxide. So we use a VV ECMO to support the lung system. Another form is a VIA ECMO. It's provide both a cardiac and respiratory support for the patient with a severe heart failure. And all those patients, sometimes they have both sides of heart, right heart and left heart failure. So they can get a better oxygenation at the same time if they have the bad circulation. So I put a patient on a VIA ECMO. You, like the diagram showed, you drain the blood from the patient from a big vein, and then through the pump, oxygenator, get oxygen, and then pumping back to the artery system, a big artery. So that's another form of ECMO. When you decide to put a patient on VIA ECMO, if the problem, like I said, is a lung problem, you'll probably put on VV ECMO. But if the patient have a respiratory problem, it is also at the same time has a circulation problem, it need a heart support. So that time we will also consider to put a patient on the VIA ECMO. And of course, and a patient has a primary disease of a heart problem caused heart failure, then we also need to put the patient on ECMO. So the underlying pathology and hemodynamic stability of the patient, also the oxygenation and ventilation status of the patient. So decide which mode of ECMO we're going to use on this patient. Half century after Donahue and Dr. Bartlett, so the ECMO system, so they transform from a big, bulky, and then looking a very busy system to a compact and then a more high efficient. So we can even bring the system to the field, to the patient. This is the old system. When we talk about ECMO, in our mind is always thinking about in ICU, besides the patient's bed, there's a large complex system, yes, predominantly in ICU or operating room. So they have a large console with an integrated pump and then controls. And they also have a bulky oxygenator, and most of the time have a separate heat cooler, heat exchanger. They have a numerous tubing and wire and associated monitor equipment around the patient. And then the size and the weight is significant. Usually require a dedicated space to put that system. And then this system is designed for stationary use, so they can move around. And then also need a continuous AC power supply to power the system. But the patient need a mobility. So sometimes we need to transfer a patient between different hospital. Like if the patient put on a small hospital for the emergency, and usually we need to transfer the patient to a large tertiary specialized ECMO center to get a better management. And even inside a hospital, sometimes we need to move around the patient to a different department or different unit to get like a checkup or therapy. And then for some emergency situation, like a patient suffer from cardiac arrest, and then most of the time, sometimes they happen in the hospital, but a lot of time they happen outside of a hospital. And then the current system has an inability to initiate this item quickly at a site or emergency. And then sometimes when we suffer the disaster or mass casualty, they also need a lot of casualty, a lot of patient need to taking care, need to support that the current system, I mean, the bulky system cannot bring. So the traditional ECMO actually is a barrier to a mobility. So the solution is we want making ECMO on the go. We want making the system. We want to bring the ECMO system to the patient, to the patient. So that's developed this ultra compact, lightweight, and battery powered ECMO system. So the goal is to provide a continual uninterrupted life support for those critical ill patient during transport and a non-traditional setting. So we need a making the pump smaller. We need to make the oxygenator smaller. Also the hardware, the control unit. And also we want to enhance the battery technology to supply time. And then static therapy into a dynamic, most of the hospital in order to the treatment to the patient. So we need to build an ECMO system small enough, can hold in the ambulance, can put in a air flight or helicopter. So that ways we can bring the system to the patient, to the scene, to get the first time support for those emergency patient. Out of a hospital cardiac arrest, usually need not a compact unit. You need a dedicated ECMO team. So they included an emergency physician, a perfusionist, and then also the compact, easy carry ECMO system ready to go. So they can reach the emergency in minutes to save the patient. ECPR in a pre-hospital setting, like the cardiac arrest can happen in the hospital and outside the hospital. When this happens, the vital organ, the heart, the brain, and the kidney and liver, they don't have blood supply. So we need to initiate the advanced life support immediately. So usually we do the CPR, the chest compression at the site. I mean, whenever it's happened, you need to starting the chest compression immediately. And then if it happened in the hospital, if we have an ECMO team or ECMO unit, then we can, once we initiate, we contact the ECMO team, we can bring the ECMO to the patient, we can put the patient on via ECMO. So that's eCPR. And then if the patient if this cardiac arrest happen outside the hospital, then usually two ways to deal with this. Sometimes it's the most of the time actually, we will start a CPR right at the scene, and while the CPR patient under the CPR, we transfer the patient to the closest hospital with this extracorporeal life support ability. So we at the ER of that hospital, we put the patient on ECMO in the hospital. And then the other way is we bring the ECMO team, we bring the ECMO system to the patient, to the scene. While we're doing the CPR, then we put ECMO on the scene. So then we transfer the patient with ECMO to an ECMO center or to a dedicated the unit to get a further management. So the precondition for ECMO out of hospital, you need a system ready all the time, 24/7. And then you need a easy way to bring the system or bring the team to the scene, to the patient. So you either using an ambulance or using a helicopter. And then, like I said, you also need a compact, easy carry, lightweight, the system. So that way we can easily to bring the system without any hassle. The same thing happened at disaster. Whenever any disaster happened or a pandemic happened, there's a lot of casualty, a lot of patients need support in a critical condition. So that's why that's if we can bring our system, the support system to the field, to the patient, we can save more patients. We can get a better result. So then when you talk about why we need a portable ECMO system, we already have a system in the hospital, then why we need making it small, making it portable. So this is the reason is that we want to improve the access to the care. We enable transfer of this complex patient from a small facility to a specialized ECMO center. So we need doing a patient transfer. Also, we want to expand the reach of the life-saving therapy. So to giving those life-saving method or life-saving opportunity to those needed patient. And now when we transfer the patient, we want to reduce the risk associated with the patient movement by maintaining continuous support. So we want to move the patient at the same time, not interrupt the support, not interrupt the therapy. And then facilitate initiation of ECMO in emergency situation. We either in the ER, a cath lab, or even in a pre-hospital setting, like the cardiac arrest happened outside the hospital, ECPR. So that way we can improve the survival rates by shortening the time for the intervention. To give us allow the necessary, if we have this compact system, we can move patient around, also allow the patient for a necessary diagnosis procedure or therapy for those required patient movement. Look back from ECMO evolution. So from the early 70s to 80s, that time was from the pioneer work of Dr. Barley. That's the early clinical success of ECMO. So that time, the system we all know is a complex system. They have a lot of complication happen on those systems. It's the technology progress in the 90s. So when we introduced centrifugal pump and the heparin-coated circuit, they much improved the safety and the efficiency. But still, the system is large, it's stationary, and then it's not easy for patient transfer. By the year 2000, at that time, the miniature beginning with the integration of components. The most of our popular system is Maquette Cardio Help. That still is a manpower horse in the clinic. So that's an early attempt to the compact system. After 10 years, in the year 2010 and up to present, current now, is there are many couple of development on the true ultra compact and battery powered system on the market. It's optimized for the transport. So this widespread adoption of mobile application. Later on, I can show you a couple of systems right now current on the market. But when we're talking about an ultra compact system, they still need all those components of ECMO support. We need a cannula, but we need a cannula for this transport patient or this moving patient. We need to consider a different cannula site or cannula technology. Also, we need a blood pump to generate better flow, the better hemodynamic flow, and then a better biocompatibility, also a good hemodynamic support. And also we need the oxygenator. We need a better designed oxygenator, making it smaller, making it as a less priming volume, as a high efficiency for oxygenation and CO2 remove. And then a better heat exchanger to regulate the patient's temperature to prevent hypothermia. And also the tubing system, the specialized biocompatible tubing connect all component is designed also for a minimal. We want to minimal the priming volume. And then a user-friendly control panel, the control console. We can manage the pump speed, monitor the pressure, and then important parameter. We can setting an alarm. It can adjust a different support mode on this console. So we're making the system smaller, but we are not going to compromise all this function on the regular console. Yeah, like the pump system, we want to make the pump smaller. We want to making it using a less priming volume, and then so they can have a better biocompatibility to reduce blood trauma, to gentle to the blood compared to the older, bigger centrifugal pump or old time roller pump. And then we need a compact size, can be making it smaller and lightweight to reduce the whole weight of the system. We need a flow control, precisely regulated flow based on the pump speed. And then the design consideration is minimal the priming volume, also has a robust construction for transport. The same as oxygenator. We need a better material. We need a better oxygen membrane for a better a gas exchanger. So to get a better oxygenation and the CO2 remove. So the oxygenator are often integrate directly with a heat exchanger. So we can build it together. We can design a high efficiency in a small unit. Also, we need the system need power, right? So we need a unplugged system on the move. So we need a high capacity rechargeable lithium-ion battery. That's a standard. So usually this type of battery can provide 4 to 6 hours with a continuous operation, well, depending on the system and the flow. And also when the battery, the power of the battery deplete, when we want to change the battery, we want a hot swappable. So we want to, when we're changing the battery, not interrupt the ECMO support. And then also this battery can be charged by a regular AC power wall outlet, and also can be charged by a DC power from the vehicle, ambulance or helicopter power supply. So then we usually we can have a multiple battery pack always carried during the patient transport to ensure there's an uninterrupted power supply. And then the monitor system, the system also for the battery, we want to know they have a clear battery level indicator or alarm. So when the battery power is low, they alert the clinician to changing the battery. So those are the requirements for the power system. This portable ECMO really saving life. The data say. So from the ELSO data, we can see the across-center study, the ECMO transport achieve a stable survival rate of 60 to 70%, confirming its safety and clinical effectiveness, even with a growing transport volume. So the overall survival to decannulation is 77%, and the survival to hospital discharge 64%. The interfacility ECMO transport, the survival rate also can reach 62%. So, which means the transfer is safe for the ECMO patient. The economy equation. If we're making the ECMO system smaller, compact, or higher efficiency, or you need to spend more money. So there's an initial cost and operation cost associated with this ultra compact system or ECMO on the go. So for higher, so for the compact system, the cannula or associated disposable, we need a higher capital investment. Also, you need a dedicated team. You need a specialized training for this. Also, for the transport team and for the maintenance, for the supply. So the initial cost and operation cost may be higher compared to a regular ECMO usage. But in the long run, the long term, there's a cost effectiveness. They can improve the patient outcome. They reach a higher survival rate, means a more productive life being saved and reducing a long-term disability cost, and also reduce the length of the stay. So the facilitating a timely transfer to a specialized ECMO center can potentially shorten the overall hospital stay. And also the in-time transfer a patient to a center, to a specialized center, can avoid complication. They can prevent this costly complication associated with interrupted care or unstable transfer. And then they can position the institution at the institution, the hospital has a ability to do an ECMO transfer and has a specialized ECMO transfer program or team. They can position the institution as a leader in the critical care transport. But ECMO transfer is a complex, it's a systemic operation. Actually, there's a lot of you need consideration. There's a patient stabilization consideration. You need to optimize the hemodynamic, also the ventilation, also the patient sedation. Usually, that's a copy from one of the hospital's ECMO transfer checklist. You need a checklist to make sure each step, each component to be checked, to be made sure for the safety of the transfer. So we need to make sure every connection are secured. We want a operator flow and pressure and gas exchange during the transfer. Also, we want to inspect any error in the circuit or any problem happening in the circuit. And then we want to make sure the power supply and the gas supply is enough, is safe for the transfer. And then also on the patient side, the patient management side, so we need to prepare all the necessary medication, and then so for the ensure all the monitor equipment is charged and functional, especially for the cannula side inspection. We want to make sure the cannula is secure to avoid any bleeding or kinking or any cannula site problem to prevent this dislodgement of the cannula. Usually, we can reinforce the dressing or any fasten way to secure the cannula during the transfer. Also, we need a better communication to confirm receipt of patient at the receiving facility, and then to briefing the transfer team about the situation, about anything happened during the transfer. So this is a lot of things we need to make sure to be confirmed. ECMO transfer need a specialized team. They including a ECMO physician, perfusionist, EMT flight crew, and then a critical care nurse, and also the respiratory therapist to ensure the patient safe and then not interrupt of the support during the transport. And this needs to be trained, to be highly training the special team. Due to this, the training is essential for all team members. So we need not a didactic training from the knowledge wide. Also, we need a higher fidelity simulation to simulate the scenario it when happened during the transfer, and also to let the transfer team to familiar how to deal with those complication or problem or happening during the transfer. So to emphasize their communication, leadership, and teamwork under pressure. And then those training, we need a recertification, we need a regular refresh the course and the simulation to maintain the transfer team has a proficiency for all this skill and the technology. So navigating the roadblock, the challenge during the portable ECMO is they're including a technical challenging, also clinical challenging. The technical challenging, like a battery management. So we want sufficient power, sufficient battery, and for the entire journey. So we don't want any power interruption or support interruption. So also the equipment failure. So during the transfer, there's vibration, there's movement for the equipment. So there's a pumping make alarm. There's oxygenating, maybe in bumping or they have a malfunction or circuit integration during the transfer, during the patient move has a problem that also need to be that's a challenge. And also when we transfer, we usually in a very tiny space with a constraint. Either in ambulance or helicopter. The transport team need to have the skill, have the ability to operating in a cramping environment. From clinical side, the clinical challenge, like I said, the cannula completion, the dislodgement, they have a bleeding from the cannula insertion side. Also, when you transfer moving, maybe the distal perfusion, a catheter, they have a kink or they have a distal limb a perfusion problem, ischemia happen, or they have a patient instability. You're moving the patient, they're shaking during the transfer. The patient's hemodynamic they might shift, or the patient has arrhythmia happen, their neurological event happened, or anything happened to the anticoagulation management. So we need to make sure they're not clotting forming in the circuit. The patient still on the regular standard anticoagulation management, and then also has a environment factor, any temperature in cold condition, in very hot condition, very hot weather, or different altitude changing from the air transport. So all this challenging from technical and clinical facing when we thinking about ECMO on the go. So preparation is the key. So comprehensive pre-transfer assessment and contingency plan is paramount. So it's critical. So, we need a cannula management, better management. The cannula is the big things during the patient transfer. So, I mean, if there's a bleeding, we want how to stop the bleeding. We need urgent or redressing, or need just putting a pressure on the bleeding cannula site. Like I said before, there's a distal limb perfusion problem. We want to check the arterial cannula. We want to check the distal perfusion catheter, any kinking problem. And then we need to maintain an optional patient positioning to prevent any cannula kinking. And then not only cannula management, also the circuit. So, I mean, anything happen, we want to identify and the resolution of the alarm. There's any happening in the high pressure or low pressure, and then we need to make sure we have a backup component. I mean, if anything happen in the palm drive or anything happen, to the system, we have a contingency. We can to not interrupt the patient's therapy. And also for patient response, we need to continue to monitor the patient's vital sign, so that the patient's consciousness, and then to regulate administration of any medication, vessel active medication or fluid as needed. So there's a lot of consideration. So the current the portable ECMO system is this innovation in this the system from the old bulky system, the standard system, to this lightweight portable system. So we need the further miniaturization, we're making even smaller or lightweight. So it's not like just a mobile system. We need to making it as a compact, making it more smaller, more lightweight, getting easy for patient transfer. So that way, we'll consider things like we need an integrated sensor or a smart system, so they can continue real-time blood gas monitoring within the circuit. That's the future direction, and automatic flow and sweep gas adjustment based on the patient's parameter. Also, we can use AI to predict the analytic analysis of the anticipated complication or any auto adjustment of flow and any gas supply. So we'll need to consider the wireless connectivity. We can remote to monitor the patient, let a special team to remote monitor the patient, and then from the central hub. And then for better material, we need a better making the oxygen smaller. So that way we need a better biocompatibility material to have advanced coating to reduce the need anticoagulation and minimize those blood material interaction. This next generation oxygenator, we want to be a long-lasting and high, more efficient membrane. And then if we want to reduce the oxygenator, we can even think about artificial hemoglobin carrier. So using this, that's a distant possibility to reduce the need for the complex oxygenator. So the transformation of the ECMO system from the standard bulky system to an ultra-compact system has fundamentally changed the landscape of critical care of patient transport. They empower the clinician to bring advanced life support to patient, rather than the patient always have to go to the hospital, go to the fixed life support. And then by enhancing the access to a specialized care and enable safer transfer, they are directly contribute to improve patient survival and quality of life. Continual innovation promise even a more accessible and efficient or integrated ECMO solution, further solidifying its role as a vital mobile therapy. Well, some deep diving about this component when we consider making this ECMO system smaller, compact, or even ultra compact. So, like I said before, the pump head. So we want to design the pump head has a better hemodynamic, can reduce hemolysis, making it smaller, has a less priming volume. The same thing as oxygenator. For the better material, get a high efficiency gas transfer and with the integration of the heat exchanger. So that way we can minimize the whole system and at the same time provide a high efficient gas exchange. And also the cannula, where not the cannula from the material, from the cannula design, and also the way to cannula, to put the cannula and the position of the cannula, how to put the cannula. Like right now, we not have we also, right now currently in the market, we have a dual lumen cannula at the same time to provide drainage and infusion to the system. Accessing circulation, critical on the go, that's the cannula. Like I said, it's a cannula is for ECMO patient, especially during the transfer, during the patient movement, it's critical. So when we consider the mobile ECMO, they usually, we have to consider a different cannulation, like the way to cannulate and the cannulation site. Not like a regular for the patient in the ICU or in OR. The most cannulation we use the femoral cannulation, the femoral vein and femoral artery, because the vessel is big, it's easy to do cannulation. But for this patient transfer, you want patient move, you move the patient. So it's better is to move the patient, to move the cannula. The most of the time we use internal jugular vein or subclavian or axillary artery to move the cannula to the upper part of the body. That way you can away from the gray area, easy for the clinician to monitor the cannula site, and then also provide the patient for a better mobility. And then also the manage an anticoagulant system on the go. And when doing a patient transfer or mobile ECMO, the anticoagulation is other things need to focus on. So we know ECMO, we need an anticoagulant patient to prevent the clotting forming in the system. So we need giving patient heparin to anticoagulate. So if any, that's the same problem you deal is a regular, ECMO management. If the patient has a problem with heparin, like a heparin-induced thrombocytopenia, then you need to consider use an alternative. You need a different way to anticoagulate. So the challenge of the transport is they have a limited lab access. You cannot do a lot of lab testing like we regular do in a hospital ICU. So that way, so you only maybe use a point of care devices to do a ACT or any a simple assessment of anticoagulation. So also have the environment to affecting the ECMO system calibration, like maybe in a higher altitude or in a very cold condition, or in a very hot environment. And then and also the transfer, because the patient move, because when we move the patient, will also increase the risk of bleeding due to movement trauma. So they have a strict and standardized protocol you need to develop for mobile ECMO. And then when you transfer the patient, you need a troubleshooting the alarm. Any alarm happen during the transfer. So the alarm management during the transfer is also very critical. And then to pay attention about any high pressure alarm or low pressure alarm because of the tubing kink or cannula kink or any disconnection or cause major leak, or a patient has volume situation, hypovolemic, or cannula dislodgement, or because of the cannula position or the cannula kink, they cause a pump cavitation. And also they have a flow alarm. You need to pay attention about either the patient malposition, the cannula, the cannula malposition, and then the volume condition of the patient. If the air happen in the system, you need an emergency protocol to how to de-air the system. Maybe you need changing another circuit. So all these things need to be considered. And also this battery, make sure that the battery have enough power to supply the battery, a low battery alarm. So you need to initiate a hot swap procedure to switch the battery. That's why we develop this Y cable. So at the same time, you can swap changing the battery, and then at the same time continue the support. And then the troubleshooting strategy is you first check the patient, and then you check the circuit, and finally check the machine. So make sure every procedure, every step is correct. Every problem need to be fixed during the transfer. I'll summarize this couple of compact ECMO systems right now current on the market. Still, right now current still a lot of hospital using cardio help. This is still a major, consider a compact ECMO system on the market. One is that their system is quite small. You can fit on the bed. You can fit on the transfer vehicle, and also the special design at their oxygenator pump head is integrated. So there's a one unit with a pump head and the oxygenator. And then this the lower part is a second generation of cardio help. It's making a more sleek, more compact. And then Euro set, they have another compact system. They have a regular backpack styled the system. Also, they're making a even smaller system for this pre-hospital ECMO out of hospital use or patient transfer use. The same as Spectrum, they have also besides their mobile ECMO mode, ECMO transfer unit, and they also make it a smaller, more compact system. It is a picture on the right. And then for thickness, can convert to a compact system, easy for patient transfer. Also, LivaNova has a system that you can do a patient transfer or ECMO, mobile ECMO. There's more a system. Abbott, they combine your set oxygenator with this their system with a central mag pump. They're making this a compact system. On the lower left corner, you can also see the second generation of road flow. They're making the system even smaller. So compared to the old system, they're getting more lightweight. They're good for transfer. And also a car system. They use a lot of it in Europe. And then on the right side is a Lifemotion. which later on will give a little introduction or Lifemotion system. They can easy to do a mobile ECMO. They can easy for transfer patient. And there's also another system is a pneumatic powered ECMO system, which I don't see a lot of it in the clinic on the hospital, in the hospital. This is our Lifemotion ECMO system. This is considered a pretty new system on the market. We first get a Chinese FDA approval in 2023. Is on the market. So you can see the system has a pretty standard format. It's a bedside unit. They have a cart, and then the cart you can bigger size monitor for easy to monitor those parameter and adjust alarm. And also the unit can be lift up and down on the cart to facilitate the patient position and the patient maneuver in the unit. Also, you can convert from the standard bedside mode to a transfer mode, which is a mobile on the mobile mode. It's easy for patient transfer. This is only weight 11 kilo, the transfer mode. So, and then we have we also provide the oxygenator, Lifemotion oxygenator, and the Lifemotion pump head, a central pump head, and the whole circuit. This is we get approved in Chinese FDA in early 2023. Has been on the Chinese market for 2 years. There have been over 3,000 cases been done in China, and then we get a CE approval January this year. So there are several European countries has been using Germany, Spain, Italy, several Denmark, several European countries starting using. Right now, we're working on the approval by FDA, and also get a regulatory on the other part of the country. There are already a case using in Chile, in Latin American. Also get a registration in South Africa. We're starting using there soon. So that's our Lifemotion system. And then we'll talk about the ECMO on the go or a compact ECMO system, especially for those emergency for ECPR out of the hospital. And then we want to make the system simple. We want the simplification of the system. So usually the clinician we think about is the system can provide a low flow support, at least 2.5 liter to 3 liter flow, and then we want a smaller cannula size for easy insertion on the field. And then one, of course, is a VA ECMO, one in the arterial, one in the venous. So, and then the cannula side should be on the same side. So that way you can easy to facilitate cannulation. But usually it's a femoral cannulation. It is a big vessel. Is a support easy to expose the cannula side for easy cannulation. And then we need a simplified ECMO system. So they said we only need the system can on and off and provide a display of flow. So that's enough. So you can get rid of this. I mean, if the monitoring accessory are bigger, then we want to making it a lightweight. Then you can get rid of these things. As long as we have an on, off, and the flow indicator, we know the flow. So we can continue the CPR with the same time provide a patient with a low flow support, and then we can transfer patient to an ECMO center to the ER to get a better optimize any supporting parameter. With the same idea, so we design an ultra compact system. So right now it's still on the research development phase. It's hopefully soon will be on the market. So this is a really concept ECMO in the pack. So you can see in the pack, they have a pump head, they have a holder, just a holder, and then they have a 2 battery, and with a white cable, which allow you when you swap the battery, so there's an uninterrupted for support. And then so you can see the system is quite small. You can put up besides patient's leg will for transfer the patient. Now I want to do some case study or clinical application about the compact ECMO system. So this is 2010 in Germany, Regensburg, Germany. They report ECPR out of hospital. Actually, this is a worldwide first case to report ECPR on the scene. So this is a 9 years old girl with a cardiac arrest after a warm water drowning, and then the patient had a cardiac arrest, and then they did a percutaneous cannulation via ECMO, and they're using their mini ECMO system, portable mini ECMO system. Actually, they just modified this road flow system with their own design, the frame. They're making it portable, this system. So they put the patient on ECMO support, but unfortunately, the patient didn't survive. But the case showed the minimum ECMO support can be used to restore effective circulation and gas exchange in an out of hospital situation or condition. So, oh, sorry. I don't see the picture. Oh, maybe this is for ambulance transfer. There's no picture. So, oh, sorry. The picture not showing here. Actually, I'm sorry. So, but I just briefing, doing a case report. There's a young patient suffer from fulminant myocarditis. So they put a patient on an ECMO, and then in a small community hospital, and then later on they transfer the patient with this portable portable ECMO system, doing a 600 kilometer long distance transfer. They transfer patient to a ECMO center to get a better management. The patient later on fully recovered. So they can show the compact system has an important role during the patient transfer. And this also, I'm sorry, the picture is not showing here. And then this is a helicopter transfer. The same thing happened. The patient, they put a patient, cardiac arrest patient, doing a ECPR in a community hospital, and then the transfer patient by helicopter to a ECMO center to get a further management, further treatment. This is out of a hospital cardiac arrest. This happened in the early morning. The patient is a 19 years student. It happened in the school. The patient had a suddenly cardiac arrest, and then the bystander starting the chest compression and then performing the CPR immediately. And at the same time, notified the ECMO team. The ECMO team arrived 32 minutes later, and then while they continue the CPR, and then this patient, this suspect is also a fulminant myocarditis. And then the ECMO team, when the ECMO team arrived on the scene, they doing a smooth cannulation. I'm sorry that there's a misspelling here. They're doing smooth cannulation. They use a 17 French femoral arterial cannula, and also a 21 French venous cannula. And after chest conventional CPR for 57 minutes, they're starting the via ECMO. And then once they starting via ECMO, the patient starting restless. I mean, which means the patient is waking up. Therefore, the neurological function, is better preserved. They're still showing the patient can move around. And then they use ambulance transfer to the ER. So this patient later get a ECMO team management and later fully recovered, discharged from the hospital without any neurological damage. This is also this happened is inside the hospital. This is in-hospital cardiac arrest. This is a 44 years old male with 8-hour chest pain, and then consciousness changing, and then develop VFib, and then the patient has a cardiac arrest in the unit, so they immediately start aggressive resuscitation with a conventional chest compression, and then they transfer the patient to the ER, to the ER department, where the VA ECMO they initiate over there. So the patient, after starting the ECPR, the ECMO, VA ECMO, the patient, the sinus rhythm recovered, and then also have a normalized pupil size, and then you improve responsiveness. So then later they transfer this patient from this hospital ER to a ECMO center with ongoing ECMO support. So the ECMO center, the emergency PCI performed involving 90% paroxysmal LAD stenosis, and then even though the patient is successful revascularization of the patient, and then despite of intraoperative recurrent VFib, and the patient's post PCI receive a comprehensive care. The patient has they're weaning the ECMO on the day 9 and extubate the patient on the day 12. The patient achieve a fully neurologically recovery, and then transfer out of the ICU. This very long, prolonged cardiac arrest. I think this patient, they doing convention chest compression is 155 minutes, and then they put on ECMO. So we have a paper published on this case, which lower bottom, they show the publication of the journal. So this is like a consider a more prolonged cardiac arrest, a ECPR case. This case is our first using Lifemotion ECMO system, and doing ECMO, also doing a transfer, patient transfer, air transfer, ambulance transfer. The first ECMO case used Lifemotion system in Santiago, Chile. This patient is also a fulminant myocarditis. They put on ECMO in a community hospital. Urgently air transfer the patient to a ECMO specialized receiver to receive ECMO support for 5 days, and everything went smooth, and so the patient later weaned off and successfully recovered. So the ECMO portable mode, Lifemotion portable mode, is convenient and safe for patient transfer. This is another case. They report in Hanover, Germany. That's an application of portable body venous ECMO device in a bridge to transplant setting. So this is a 33 years female with end stage biventricular failure with severe hypertrophy cardiomyopathy. The patient need a heart transplant, so they initially performing a femoral via ECMO, and then after 6 days of temporary this mechanical support system, they switch to an upper body cannulation with ECMO to go. They using a tandem heart driver. They use a tandem lung oxygenator, so that way they enable the patient portability for ambulation on the device. Also, you can bring the patient to on-device X-ray examination. Also, doing a physical therapy to prepare for the heart transplant. The patient has uncomplicated fully mobilization. They can walk 200 meters. Device imaging. The patient receive a heart transplant in 30 days. So this wearable and portable mitigate immobility related to a complication and enhance the pre-transplant condition, optimizing the upper body cannulation, eliminate femoral access restriction, which is better for clinical clinician to monitor, to observation. And this modular vest carry design will remove external tripping hazard to boost mobility freedom versus a conventional setup, and facilitate on-device diagnostic imaging, so without any disruption of the support. So the adaptable, diverse ECMO configuration offer a feasible tool for active bridge to a transplant patient with increased waiting time. So this is really ECMO on the go, and then portable. This is all my presentation. If any you have any questions, so we can discuss from here.
Well done. Wow. Thank you so much.
Thank you.
So I have time for a few questions that will fit in there. I know we've gone a little bit longer, but that presentation was really good. I loved the case studies and the actual examples of this technology in action. Do you think AI will be able to predict when flow adjustments are going to be needed if there's transport conditions, for example, vibration or altitude or temperature? Is AI going to help us with more safe transportation?
Yes, definitely. We are going to help us. They can give us prediction based on this, vast amount of data. Of course, they can provide us. They can is a guidance or a reference for us.
Mm-hmm. And when it comes to safe transport, like what type of fastening or stabilizing innovations are going to be needed to be able to transport, whether it's ground or in the air, any type of offsite environment?
Okay. So usually we want to bring the the ECMO system close to the patient. So that
Mm-hmm.
ways you can shorten the tubing line, and then you can when you're moving the patient, you can easy to move the you don't have a long tubing stretch. So one is close to the patient. One is when doing a patient transfer in a moving object, like in a vehicle, in an ambulance, or in a helicopter, you need
Mm-hmm.
some kind of a bracket. Either you can like a multi-purpose bracket. You can fix the unit on the bed side, on the patient bed. Also, you can
Mm-hmm.
fix the devices on the helicopter floor or ambulance floor, so get a steady and then secured for safety.
What about the type of connection and internet speed? How reliable and secure does it have to be? Like, do we have to be connecting to satellites and 5G technology if we want to be able to have continuous
All
monitoring?
right. When we talk about the connectivity, we also think about two things. One is cybersecurity. One is secure. How we can keep the connection, not to disconnect. Better connection. So either Wi-Fi or satellite, a new technology on the horizon, so it can provide and also a better cyber security. That's all dependent. This is a possible. It's a very promising if the technology keep progressing.
And can ECMO devices transmit real-time data even to remote specialists? Is that possible?
Yes, that's possible. Actually, right now, and Spectrum system they integrate of Epic software, the data management system. They already can provide a real time data transfer to the to do a remote monitoring.
Okay. Well, thank you so much for answering all of those questions and for being so generous with your time today. I know I've learned a lot, so I'm glad we have recorded today's session and it's going to be available on demand for people to go back and watch because they're going to have a lot of notes. So, thank you so much, Dr. Liang and Heartbeat Perfusion Solutions, who has put on today's conference. They are a national provider of specialized perfusion and extracorporeal membrane oxygenation services. They offer critical support for cardiac surgeries and patients who require advanced life support. They work alongside hospitals, surgical teams, and really aim to ensure optimal patient outcomes. You can learn more at their website,
Thanks.
heartbeatperfusion.com. Thank you again so much for being here, Dr. Liang, and for everyone who's tuned in.